Hello, welcome to our JACC Cardio-oncology virtual case presentation series. My name is Dr. Bonnie Key, and I'm the Founders Associate Professor of Cardio-oncology and Director of the Penn Cardio-oncology Center of Excellence at the University of Pennsylvania. I'm also the Editor-in-Chief of JACC Cardio-oncology. Today, we'll be discussing a case presentation of trastuzumab cardiotoxicity, which we all felt would be very informative for the field of JACC Cardio-oncology in our community. I wanted to introduce to you our panel. I am accompanied by Dr. Daniel Lenihan. He's Professor of Medicine and Director of the Cardio-oncology Center of Excellence at Washington University, and he's also one of the Deputy Editors at JACC Cardio-oncology. I'm also accompanied by Dr. Giuseppe Curigliano. He's an Associate Professor of Medical Oncology and Clinical Director of the Division of Early Drug Development for Innovative Therapies in the Cancer Experimental Therapeutics Program at the University of Milan and the European Institute of Oncology. Dr. Curigliano has led many of the HER2-targeted trials and is a world expert in this area. Dr. Srilakshmi Vallabhaneni, she's a cardio-oncology fellow at Washington University, and it will be presenting to us a case. Shri, why don't you get started?
So our case, she is a 74-year-old female who's been seen in the oncology clinic. She has history of hypertension, hyperlipidemia, and triple positive invasive ductal breast cancer with liver metastasis. She did receive cycle 1 of docetaxel, trastuzumab, and pertuzumab, and then docetaxel was discontinued due to palmoplantar erythrodysesthesia. And she was cycle 2 to cycle 5 of nab-paclitaxel, trastuzumab, and pertuzumab. After the 5 cycles, she has been on maintenance therapy with HER2-targeted therapy with trastuzumab and pertuzumab, and she received 1 cycle so far. So her medication-wise, for hypertension, she's on carvedilol 3.125 twice daily and furosemide 20 milligrams a day, and she takes ezetimibe 10 milligrams. Blood pressure in the oncology clinic, 175/92 with a pulse of 96. And then she did have like her baseline echocardiogram, which showed a normal LV size with a normal LVEF at 55% and normal RV size and function and mild MR. Strain analysis was not performed because this was done at an outside facility. And she also had another echo at 3 months, which was normal LV size with a function of 66% on Simpson's biplane with mild MAC and mild MR. So I would like to now ask Dr. Curigliano, like, is this a patient you would have referred to cardio-oncology?
Thanks, Shri. Yes, Giuseppe and Dan, what are your thoughts about this patient so far? Is this someone you would have referred? How useful is cardio-oncology expertise in this particular patient? What are your thoughts about her blood pressure and so forth, medications?
I believe this was a patient that should be referred to the cardio-oncology practitioner as soon as possible when you have to start a treatment with pertuzumab, trastuzumab, and docetaxel. We know very well that in the elderly population with hypertension, there is a higher risk of cardiac toxicity. We know also that the combination of pertuzumab, trastuzumab, and docetaxel will increase overall survival. So it's really crucial to have a baseline risk assessment for a patient like this for 2 reasons. First, in order to prevent cardiac toxicity. Secondly, in order to prevent treatment discontinuation, because treatment discontinuation may affect the impact on overall survival. This combination improves survival. So as a medical oncologist, I would like to have a baseline risk assessment in order to deliver my treatment in the best way possible without discontinuation and dose reduction. So this patient should be referred for cardio-oncology evaluation.
Thanks so much, Giuseppe. Dan, what do you think in terms of just recap for the community out there? Cardiovascular risk factors for toxicity, you've heard some from Giuseppe already, elderly, certainly combination therapy, certainly with anthracyclines preceding HER2-targeted therapy.
So if we look at the data, yes, if we look at the data from the HERA trial or any other trial using entire two agents, it's quite clear that the most important risk factors are elderly age, hypertension, hyperlipidemia, and obesity. So this specific patient was an elderly patient with hypertension and probably also with obesity. We don't know this because it's referred to just hyperlipidemia. But for sure, all patients with these characteristics should be referred to cardio-oncology evaluation before starting any treatment with anthracycline or entire two agents, both in the adjuvant setting and in the metastatic setting.
Thanks so much, Giuseppe.
Yeah, Bonnie, I think, Giuseppe is, for the most part, I would say he's probably ahead of the game in general. I think that at least what I have observed in practice and, at least in the United States is that in such a patient, most likely they would be treated with whatever combination the oncologist felt was good. And as long as they didn't develop any cardiac issue, then they wouldn't necessarily refer this patient. But as Giuseppe said, she already, before she even started therapy, was already marked as a high-risk patient because of her age and cardiovascular risk factors. And I think this is especially a place where I think cardiology could be very helpful. So we can, I think that if an oncologist sees a patient and they go through all the x-rays and the biopsies and all the data about this combination of drugs and some other combination of drugs, whether or not they need surgery and radiation and all that, there's no time for them to talk about, how do you manage high blood pressure better or something along that line. So I think that this is a place where cardio-oncology can be particularly helpful in managing those issues.
Thanks, Dan. I think that's really an excellent point. And I think you're true. I think you're also the statement that you made that Giuseppe's probably ahead of the curve is probably a valid point, because we know, at least in the U.S., not every patient with cardiovascular risk factors is referred, but we do think as cardiologists that we can have a positive impact through the aggressive management of cardiovascular risk factors. So as practical advice for our audience out there, I think it's reasonable to potentially suggest, and of course, in close partnership with the oncologist, the cardiologist, and the patient, that patients with multiple cardiovascular risk factors who are receiving high-risk treatment regimens that are potentially cardiotoxic should be evaluated by a cardiologist. I also wanted to add, what do you think about the blood pressure, and what agents would you start, Dan, if you were seeing this patient in clinic to better control the blood pressure? What are your go-to therapies?
Well, certainly if anybody's talked to me more than one time in their life, then they'll know that carvedilol is one of my favorite drugs. So that's an excellent therapy. It's just at a teeny tiny little dose. And, clearly you would want to have a more appropriate dose for this patient. She was certainly hypertensive, but also somewhat tachycardic. And then there are trials looking at patients who have normal function going into chemotherapy, that carvedilol is potentially beneficial. And there's some that have even been pretty convincing that carvedilol is an excellent choice. Other drugs that you would put on that list are drugs that we are typically very comfortable with in people that have heart failure. So those would be ACE inhibitors or ARBs or some combination of those therapies. And so carvedilol is certainly a fine drug, and I would say, just maximizing the dose and then discussing the ways in which we manage the potential of heart failure and manage other non-pharmacologic management of high blood pressure that you would want to emphasize with the patient.
Those are great points. Dan, certainly there have been a number of cardioprotective studies that have been published. The USF study, the SESI study, the USF one in the trastuzumab as well, the population, as well as anthracyclines plus trastuzumab, demonstrating a benefit with carvedilol and lisinopril in the patients receiving combination therapy, i.e. anthracyclines and trastuzumab. And certainly we also published a meta-analysis in JACC Cardio-oncology last year that demonstrated that with neurohormonal therapy, there's about a 4% attenuation, the decline in EF. So excellent points. I would reach for those same therapies. And Giuseppe, just one last point to touch upon before we move on, but talk to us a little bit about the cardiotoxicity observed with combination HER2 therapy, i.e. trastuzumab as well as pertuzumab.
You know, if we look at the data of the Cleopatra, of course, there is no increase in terms of heart failure by the combination of the dual blockade. And also in the adjuvant setting, when you use pertuzumab and trastuzumab, there is much more cardiac event, but not an increase of heart failure. Of course, we know very well that in the elderly population with risk factors like obesity, smoking status, and hypertension, there is a higher risk of heart failure. So it's a good reason, as guidelines actually report, to refer all these patients with specific risk factors to the cardio-oncologist in order to do a baseline assessment of the risk. In Europe, this is very important. In Europe, we refer to the cardio-oncologist all patients, even if they don't have a risk. So also a patient fit with no problem is referred to the cardiologist at baseline. So the best practice, in my opinion, is every time you have to receive anthracycline or dual blockade with pertuzumab and trastuzumab, is to do a baseline assessment with the cardio-oncologist. This is more safe for the patient, and this will guarantee to you also the opportunity to deliver the care without discontinuation and without dose reduction.
Thanks so much, Giuseppe. Moving on, Sri, do you want to talk to us a little bit about this study that we published in JACC Cardio-oncology?
Yes,
yeah.
sure. This was a study which came out of University of Pennsylvania, and they've retrospectively looked at like patients who get trastuzumab, and cardiology involvement in these patients is associated with significantly increased adherence to guideline recommended monitoring as well, and greater assessment of biomarkers as well in these patients. And they had better control of their hypertension and with lower BMI in this population as well.
And in our own Penn experience, actually 20% of the patients were referred to cardiology within our center. But interesting to see the differences in geographically.
Yeah. So going back to our patient, after 4 months of targeted therapy, she was actually admitted to the hospital with acute cholecystitis and cholelithiasis, and she underwent a laparoscopic cholecystectomy and ERCP, which was complicated with hypoxia requiring intubation overnight, thought to be related to neuromuscular blockade. And during that time, she did have an NT-proBNP done, which was significantly elevated at 1919 picograms per ml. And post 1 month after that, she had an echocardiogram done, which you could see like on the parasternal long axis views, like her LV function is reduced. She does have some mild MR, and on the short axis view, the LV, the EF is mild to moderately reduced, and we also have an apical 2-chamber view, and the LVEF calculated by Simpson's biplane came at 42%. So at this point, she did have a drop in LVEF, so her dual HER2 therapy was held, and she was referred to our cardio-oncology clinic here. And in the clinic, on evaluating her, she had NYHA class 2 symptoms, and her blood pressure was 130/78 with a pulse of 95. So we increased her carvedilol to 6.25 and also started her on ACE inhibitor with lisinopril 5 milligrams daily. And the plan was to repeat a transthoracic echo in 4 weeks. So she underwent a repeat echo in 4 weeks, and this showed again on the parasternal long, the LVEF. It's still it's still mildly reduced, but it's improved compared to before. The LVEF calculated by Simpson's biplane now is around like 49%, she remains to be NYHA class 2, and she has been on carvedilol 6.25 twice daily and lisinopril with good blood pressure control. And now I would again like to open the discussion. What would you advise regarding the HER2-targeted therapy in this patient now?
Giuseppe, what are your thoughts here, as well as Dan?
Okay, of course, if you have a decrease of the left ventricular ejection fraction, you need to support the patient with a cardio-oncology therapy in order to start again the targeted therapy. So my advice is to refer the patient to the cardio-oncologist to start an appropriate treatment. And once you see a recovery, also a beginning of recovery, you start again dual blockade, because it's crucial to deliver this type of treatment since it will improve survival. So your help is essential here.
Yeah, so this is a really challenging case in many ways when you start getting into the detail. Absolutely, I agree with what Giuseppe said before. If we had been aggressive about managing her cardiac risk factors before, I think we could have prevented this LV dysfunction. As you saw, even by just doing a relatively simple manipulation of her medications in a short period of time, there was already an improvement in the LVEF. The other point that I would make, and Bonnie, you sort of mentioned this a second ago, about at Penn, it's more common that you would measure biomarkers. I am very much a biomarker proponent. I think it helps us guide therapy. It also helps us diagnose heart failure where it previously would not have been diagnosed. And so in this case, when the patient went in for acute cholecystitis and had an NT-proBNP that was almost 2,000, that's clear evidence of heart failure, in this case with most likely a preserved EF, but nonetheless, she's already developing heart failure, and it's absolutely mandatory that you have them on the most cardioprotective medications going forward. So I think whether to start or restart the targeted therapy is an important question, but without any doubt, and I would say it's really substandard practice if you don't maximize their cardioprotective therapy at this point. So I think that's, from a cardiology point of view, that is the most important thing at this time.
Those are excellent clinical pearls and teaching points from both of you. So number one, absolutely maximize cardioprotective therapy, target, and I believe also not only neurohormonal antagonists, but also intensive blood pressure control, and try to impress upon patients that their blood pressure really needs to be well controlled in order to help mitigate cardiotoxicity risk. Of course, it's a balance. We don't want our patients being lightheaded and dizzy and too low, but really I try to target systolic in the 120s. And I want to touch upon two additional points that you both raised. First, Giuseppe, tell us a little bit about the impact of holding 1 to 2 cycles of trastuzumab therapy in terms of what we know from retrospective analyses as well as clinical data. What's the impact in terms of patient survival? And what's the association between duration of HER2-targeted therapy and overall outcomes?
Setting that you should not discontinue trastuzumab. A prospective randomized trial has been done by the German breast group many years ago. And when you compare treatment discontinuation to maintenance, there is a decrease in terms of progression-free survival and overall survival. Stopping treatment for 1 or 2 administration will not impact on the outcome of the patient, but permanent discontinuation may be a problem.
And so when you see a patient who's developed LV dysfunction, of course, in collaboration with a cardiologist, how many cycles just on average are you holding? One to 2 until cardiac function recovers, or is that
usually from 1 to 3 you recover? If you don't have a severe heart failure, patients with previous treatment with anthracyclines, usually you recover from 1 to 3 omission of administration. Yes, sometimes also yearly.
Mm-hmm. Yeah. And certainly data that Tom Suter always talks about from the Harris study, it's sometimes just with the next, repeating an echo in 4 weeks, oftentimes, at least in HERA, although we know that there's different inclusion-exclusion criteria, patients would recover their cardiac function as well.
Yeah, I think that point Tom Suter has made many times in the past, but I would argue differently. Mm-hmm. If you are the patient who has LV dysfunction, even if it was only defined one time, you really don't want that again. So I think that, heart failure is a very serious diagnosis, and it will have the most important impact on these patients. So just saying, oh, this one time the LVEF is low, it's okay, I can just sweep it under the rug and check it later, is not a strategy that I believe in. So I think it goes back to the point made before about maximizing cardioprotective therapy is absolutely critical from a cardiology point of view.
Totally agree, Dan, that we need to carefully monitor, carefully follow, as well as carefully manage the patients. And I don't ignore ejection fractions of 50% or anything less than 55. I think needs some type of attention and evaluation follow-up. Dan, I want to come back to the point about biomarkers that you raised. Tell us about how you use biomarkers in this setting. Are you checking them with each cycle? How are you acting upon that? And then also to add into that comment, how, if at all, you're using measures such as global longitudinal strain in your clinical practice?
Yeah, so you obviously know a lot about global longitudinal strain since much of your research is based on that. So I feel like in a way I'm obviously preaching to the choir, or maybe I'm preaching to the pastor. But the bottom line is that it can be a useful tool, but there are a lot of limitations in terms of strain, in terms of measurement, and then depending on the location, whether it's even measured at all. So I think that there are vendor-specific requirements, and then there's technician expertise, and then there's echo interpreter expertise, all factor in. But if done properly, I do find strain to be useful. It's another marker of LV dysfunction, different than the LVEF. And so it's really just another parameter to follow. In terms of biomarkers, I think that they're even more sensitive, and they're also not subject to interpreter variability. So you measure it and the lab gives you a number, and it's not subject to interpretation. So I think that I use it every time that I see a patient. I would measure biomarkers, or at least in this case, an NT-proBNP, just to help me guide my medical adjustment. If, for example, I saw that this NT-proBNP from the previous one of 1900, it was rising, then I would know that I'm not doing the best that I can do to protect this patient. On the other hand, if I saw this patient back again and the NT-proBNP was much better or even normalized, then I would know that my therapy is doing what it's supposed to do.
almost like a guided, but in cardio-oncology. And certainly I know you've been involved in such studies, and we at Penn are also launching some such studies in this space as well, looking to see if we can use biomarkers to better guide therapy. And but clearly wise words, and there will actually be more to come about this topic in upcoming series of JACC Cardio-oncology. So get back to our case. Shri, did you want to walk us through this paper?
Yes, yeah. This was a paper which came out of Sloan Kettering and Dr. Steingert's group, and they matched every patient who had a diagnosis of heart failure and matched them with controls. And they found out that by strict adherence to guidelines, it was not associated with a low risk of heart failure. And most importantly, patients with an LVEF less than 55% during surveillance was associated with heart failure. So, and then moving on to our point, we were talking about earlier about targeted HER2 therapy in patients with mild cardiotoxicity. This was another paper published in JACC Cardio-oncology Scholar 1 paper, where they took patients, 20 patients with early breast cancer and who had mild cardiotoxicity with an LVEF greater than 40% with NYHA class 1 or class 2 symptoms. And these patients were continued on trastuzumab along with support of cardio-oncology and clinic assessment, and also like strict guideline-directed medical therapy with ACE inhibitors or beta blockers. And over time, these of all the 20 patients, like 90% of them completed therapy, and only two patients had had to withdraw because of a drop in LVEF. And as you can see, over time, the LVEF has improved, but it's important to note that these patients have been on guideline-directed medical therapy while they were on an HER2 therapy.
Yeah, I think I would like to just make one comment here. So years ago, we published really the first experience about restarting trastuzumab after toxicity was encountered. And we reported in that initial study, this was back in 2005, that you could resume trastuzumab safely as long as patients were on appropriate cardioprotective therapy. That was a general statement, but it doesn't mean it happens in every single patient, because there are some patients that they will have either progression or recurrence of their heart failure, even though you have them on protective therapy. And I think this data, this spaghetti plot really shows that. If you see the two patients where they had a significant drop after a number of cycles of trastuzumab in this case, that, generally it's safe, but that doesn't mean it can happen in every patient. And I think you do have to monitor them carefully. So I think you have to be aware that if they've shown some susceptibility to HER2-based therapy in terms of cardiotoxicity, that they are always going to be potentially susceptible. So you have to be very careful.
That's a great point, Dan, as well. Completely agree. And there have been some studies that also have suggested a risk of late heart failure with trastuzumab therapy. That was a study published in JACC Heart Failure last year from the Danish breast cancer group.
And supporting this data, we have the Safe Heart study, which was the first prospective study on continuing trastuzumab in mild cardiotoxicity, which again had like 30 patients, of which they were continued on HER2-targeted therapy in close collaboration with Cardio-oncology. And again here, like 90% of them completed, and 3 patients, which is 10% of them, either had a decline in LVEF without a asymptomatic drop in LVEF or a cardiac event requiring them to withhold trastuzumab therapy.
So this, don't go away from that slide just yet. I think this is an important study for several reasons, but to get back to what Giuseppe said earlier, in our case, he would restart trastuzumab and pertuzumab, the data is pretty, actually, I would say it's almost non-existent that in people that developed cardiotoxicity on the combination and, say they got appropriately treated and now their heart failure or their LVEF recovered, then you could restart both the combination of trastuzumab and pertuzumab. I'm not really sure that there is any data that says that that's safe. Trastuzumab by itself, we just went through a couple of studies. I think that has been shown to be safe. But I am a little nervous about combination HER2-based therapy in somebody who developed heart failure and LV dysfunction. And if you look at this Safe Heart study, these were people that had mild LV dysfunction at baseline. They weren't those that had already developed cardiotoxicity. And with those, if you look at the group that got trastuzumab and pertuzumab, there were actually 2 out of 13 that developed worsening heart failure and LV dysfunction. So I'm just a little uneasy about the combination of trastuzumab and pertuzumab in people that actually develop heart failure and LV dysfunction. Giuseppe, I don't know what you think about that, or?
No, I completely agree with your point. It would be optimal. We don't have data, but with a left ventricular ejection fraction asymptomatic between 40 and 49, if you can support the heart function, I would really be very happy to start HER2-targeted therapies, because this is a window where you can deliver treatment if the patient is asymptomatic, and working with cardio-oncologists can guarantee also the safety of the patient. So this is really the population for which we need more trials. So this is a small trial, but doing a prospective trial in this patient population would be ideal.
These are great points, and I also, in terms of our own experiences, support that. And Dan, we've talked about this, that with pertuzumab and trastuzumab, once you suffer from an EF decline, just anecdotally at least, it feels that much harder to have the EF achieve recovery. And certainly we do hope to inform all of these important questions through additional research studies. Giuseppe, can you comment a little bit about what's on the horizon in terms of HER2-targeted therapies? What's increasingly being used now? I know there are a number of agents that are in clinical practice. Just tell the audience a little bit about.
Oh, this is a very good question. So we have 2 new drugs approved for the treatment of metastatic breast cancer. The first one is trastuzumab deruxtecan. It is an antibody drug conjugated, so it is an entire 2-agent conjugated with a chemotherapy, specifically a topoisomerase 1 inhibitor. The name is deruxtecan. And this is a very effective agent in patients with metastatic breast cancer. You can achieve almost an 80% response rate in patients HER2 positive with a medium number of previous lines, like 7, 8 previous lines. So it's a very effective agent. There is the potential of cardiac toxicity, but it's very low. It's not dissimilar respect to T-DM1. And this drug is moving in the first line setting. Then we have another agent that is tucatinib. Tucatinib is a tyrosine kinase inhibitor that has been explored in combination with the trastuzumab and capecitabine in patients progressing to T-DM1. So when you compare tucatinib, trastuzumab, and capecitabine to trastuzumab and capecitabine alone, you have an increase in overall survival, and you have also an increase in progression-free survival. So it's quite important to remember that now we have 2 new agents that improve survival in the metastatic setting. So cardiac safety will be an important issue, and cardiac risk assessment is also an important issue. We have another drug that is not approved in Europe and USA, but is approved in China, and the name is pyrotinib. It's a very effective agent, and this is another tyrosine kinase inhibitor. And what is arriving also is the use of neratinib in the metastatic setting, because we have the NANA trial comparing neratinib and capecitabine versus lapatinib and capecitabine, and the combination with neratinib is better. And finally, we are waiting for margetuximab, that is a new monoclonal antibody. So those are the agents approved or under approval. And I can anticipate to you that many new anti-HER2 agents are coming, because we have new antibody drug conjugated from Pfizer and from Seattle Genetics.
That's really exciting. Look forward to it, all that's to come. And
So
yeah.
I do have one question, Giuseppe, since you gave a great overview. One of the things that at least I feel as a cardiologist listening to oncologists discuss their different choices of medications, it's always been a question that I'm not sure I've understood the answer. But in a patient with HER2 positive breast cancer, they do seem to, if they progress, they tend to have metastatic disease to the brain. And then some of these newer agents actually cross the blood-brain barrier or are effective in metastatic brain lesions. Is this true? Is one better than the other? Or?
Yes, this is true. The best one is tucatinib. In the trial comparing tucatinib, trastuzumab, and capecitabine to capecitabine and trastuzumab, this is the HER2 CLIMB study. 46% of the patients had brain mets, and the subgroup of them progressive brain mets untreated. And it's quite clear that tucatinib may induce a response rate also in brain mets and may improve progression-free survival and overall survival also in patients with brain mets. So up to now, the best data that we have with tucatinib.
Super. And the other one that sort of jumps out at my mind is neratinib. This is a pan HER blockade. So it's blocking a little bit of HER1, blocking HER2, blocking HER3, and blocking HER4. And from the cardiology world, that makes me very nervous if you block both HER2 and HER4, since HER4 is a cardioprotective receptor. So I don't know what your experience is with neratinib in terms of cardiotoxicity.
You know, I have experience with neratinib because we use it as extended adjuvant therapy in high-risk HER2 positive disease. This is the only approval that we have in Europe. You know, in terms of cardiac safety, there is no increased risk. When you use a pan-HER2 inhibitor or a pan-epidermal growth factor receptor inhibitor, you have much more gastrointestinal toxicity. So the major adverse event related to neratinib is diarrhea, and you need to do a prophylactic therapy in order to prevent this. You know, it's also important to have a perspective in the adjuvant trial. Does not seem that neratinib, extended therapy with neratinib, increase the risk of cardiac toxicity.
Great, thank you both. And so to close, Sri, did you want to review with us the learning points?
Yeah, we've had a great discussion. So just to review the learning points, patients with multiple cardiac risk factors, history of heart failure, arrhythmias, prior anthracycline use, or advanced age should be referred to cardio-oncology. And we have data supporting that, you know, if these patients are referred to cardio-oncology, improves the adherence to guidelines and aggressive risk factor control as well. And optimal medical therapy for patients with heart failure is imperative. And for those who develop a cardiomyopathy and have heart failure or elevated biomarkers, and LVEF less than 55% is associated with a risk of heart failure. Trastuzumab can be safely re-administered in patients with LVEF more than or equal to 40% with NYHA class 1 or class 2 symptoms with close monitoring and cardioprotection.
Well, that takes us to the conclusion of our case. I wanted to thank Dan and Giuseppe and Sri for just an excellent case presentation and case discussion, which I'm sure will be helpful to all of us in the community, and encourage you to all check us out at JACC-cardiooncology.org. Thank you so much, everyone. Thank you. Have a great day.
Thank you.
Thank you.
All right. Thanks, everybody.
Thanks.
All right. Thank you.